Welcome back to episode 12 of the Rehab Exercise and Sports Therapy Podcast, sponsored by University Orthopedics. I am happy today to be joined by Rachel Lampros and Amy Devaney, who are going to talk about female athletes, something that they are infinitely more qualified to discuss than I am, since I am not a female, and calling me an athlete is definitely a loose interpretation of that word. So I'm excited today to get some of their input. Specifically, we're going to kind of hit a little bit about bone stress injuries and return to running, since they both have some expertise in that. So if you both could, Rachel, I'll let you start if you don't mind. Give us a little bit of your bio as far as your role and kind of what you do clinically.
Yeah, so I've been a physical therapist for 16 years now, something like that. It's getting upward. I forget to count and keep up with it, but a long time, longer than I would like to admit. This is like a full circle moment for me because Dan was like one of my first big mentors.
You're making me feel really old right now. Yeah.
Well, it's nice to be called on to be talking about anything because I was like a drooling idiot when I first started working with Dan. So this is wonderful. But yeah, I'm the clinical owner and founder of Kinesi in Western Mass, and our primary focus is on female athletes. I would say like our perfect avatar is like our 15 to 25-year-old female athlete. So we see a lot of ACL injuries, a lot of bone stress injuries, a lot of like patellar instability. And it's just like a really exciting time for female athletes and female professional sports. So we're just like really excited about the trends that we're seeing in the research and some emphasis on just like really helping this population. So I'm really excited to be here.
Awesome. And it's nice to know that you've managed to overcome my mentorship and go on to become very successful. So, so kudos to you. Amy, if you could give us a little bit of your background.
Yeah. Hey, so I'm Amy Devaney, and I have a similar amount of experience as Rachel. I think I'm almost coming up on 15 years of being a PT too, which is, again, sounds crazy to me. But so I've kind of worked mostly in like hospital-based systems for orthopedics and sports medicine. So I was at MGH for about half my career, and then I moved on to Newton Wellesley and kind of spanned I helped build up their sports medicine program. I also kind of worked as a supervisor and manager, so I kind of got to see the other side of things, the non-clinical side of things. And then in the past year, I opened up my own practice, and I primarily see runners, but I also definitely see, if someone's coming to me for a shoulder injury, like I kind of love that now too, because, it's a little different. So I get to still stretch my brain and work on all different parts of the body, but I do stay in the orthopedic realm. And I also do a little bit of like performance enhancement. So some people come to see me for like gait analysis specifically, and maybe they don't have, like, they may not be in PT, like they don't have a acute injury, but they've had like lots of little things and they're wanting to get those to be fixed up and then work on some performance and training for marathons. I see a lot of marathon runners in general. So yeah, it's been fun. It's been a fun new kind of realm, building up my own little practice over here.
Yeah, awesome. Rewarding also, I'm sure, right?
Yeah.
Kind of doing it for yourself. Yeah.
Definitely.
So Rachel, you alluded to it as far as some of the kind of increased notoriety now, or increased attention, I guess, going to female athletes. If both of you could, I'll let you chime in. Tell us a little bit about what you feel like some of the cultural issues are playing into female athlete injuries right now, and some of the challenges we see.
Yeah, I think that's a great question. And I think it's definitely multifactorial and a little bit layered. I think historically speaking, like the female athlete hasn't had as many resources or accessibility to things as some of our male peers. I'm an old lady now, but I can think of, even in high school, we were a state championship field hockey team, and we won in the jerseys that my coach, who won in the 80s, 20 years earlier, had won in. Well, our football team had their helmets painted every game. So, those trends I think are changing, which is really exciting. But I think that trickles down to things like with regard to sports medicine, like what sports teams are bringing in money for the schools. And with Title IX, I think there's been a real shift in finding some equity in that. And what I think we're seeing now with professional sports getting some more funding and investment is that sports medicine for women's sports medicine is really starting to get a little bit more attention and research and funding. Like FIFA just decided, I think recently, to invest in ACL prevention research, which is huge, right? So for 2025, it's a little late, but it's exciting to see this trend change.
Yeah, the image that always sticks out in my mind was the image that came out a few years ago during the NCAA basketball tournament when they kind of compared the female athletes' weight room and what they had accessible to them, and the men's, and just the stark contrast was horrendous. Yeah, I mean, so I feel like there have been some blessings that way as far as social media goes and kind of increasing people's awareness. But I feel like maybe social media is not always a great thing as far as, athletes in general now. So tell me a little bit about how much do you see as far as some of the body dysmorphia issues, and not just limited to females, but males also. I mean, again, I feel like that's an increasing problem now with social media. So tell me a little bit about what you're both seeing in your clinic, since you both see this on a more regular basis than I do.
Oh yeah, for sure. I think, and Amy could probably touch on this too, but like with especially the bone stress injuries, where we have to talk about body weight in some capacity, and you want to handle that conversation very gently, especially with our youth population, because there's a lot of social stigma about what that number is and what that number means. So I do think social media has a lot of really exciting things about getting information out there, but just making sure it's like good information, quality information, that's hard to filter, I think, for these kids that have access to it 24/7.
Yes. Yeah. As the parent of two teenagers, I spend the majority of my time like chasing them off of social media and off of screens. So I can attest that social media is not all great. Yeah, there's plenty of problems with it as well. So Amy, what do you?
Yeah, I'm actually curious. I mean, I think about this a lot actually, like because in the running world, there's always been an issue with maybe not necessarily body dysmorphia. Like it's hard to say, is it that, or is it they're trying to be at this? It used to be like the lightest that you are, the faster you're gonna run, right?
Sure.
So that kind of trend, that kind of trend has decreased a little bit. I think there's still people that are going to be dealing with body dysmorphia, right? And you're looking and comparing yourself to others. I think there has been a shift though in the trend in a good way of kind of being strong and not skinny, at least for runners. And so for female runners, there is, I think, a positive, and I hope it continues to go this way, but there's definitely more positive input in regards to, you don't have to be at your lightest. And there's actually a lot of professional runners out there right now that are, giving, their input as well. And they've even talked about previous eating disorders in college. And now that they're professional runners, they're like, honestly, you can't really do well when you get to that professional level. Like you can't really have an eating disorder and then continue to do well. It becomes a smaller scale, but in college, it's still, I would expect, I mean, I'm not in college right now. I don't have a great pulse. I don't work in a college, but it'd be interesting to see what that pulse is. Because when I was a collegiate runner, I mean, it was pretty rampant, and we all had, it was like normal to have amenorrhea like that. And if you didn't, you were probably too heavy to be running, which is a crazy thing to think about. And then down the line, right, lifespan, you're seeing all these women now kind of having issues, having kids and things like that. So I'm hoping that the trend in some ways is maybe it's kind of two-sided. It's like if we can continue to talk about, you need to be strong to perform well, and you need your body to be healthy, versus really skinny and the lightest possible weight, because that for sure ticks that risk up for, especially for bone stress injuries and red S and those energy deficiencies.
Awesome. I definitely, you mentioned so many good things in here, so I'm torn. I think if you don't mind, we'll circle back to the amenorrhea part later when we get into some of like the clinical screening discussion, that kind of thing. But I do want to talk about that because I've heard, that sometimes it becomes like the norm and almost like a convenient, again, not a female, but in some discussions about female athletes, I know that like sometimes it's not looked at as a negative to be amenorrhea, right? Like that's a matter of convenience, right? Where you don't have to deal with some of that discomfort and that kind of thing as well. So we'll circle back to that a little later if I could. But since you both are excellent clinically and very well versed in the literature, tell me about what do you see as far as the research out there on female athletes? What are some of the deficits? What are you seeing as far as some of the trends? I wanted to kind of get your perspective on that.
Yeah, I could jump in there. I think the biggest thing we're seeing is like the adolescent population, like with that uptick in injuries. And I think we're starting to recognize that these changes in hormones, whether it's adolescence or peripartum when you're pregnant, or even perimenopausal, we're starting to see these spikes in women with injuries. And so we're really starting to do a deeper dive into like what's happening physiologically. And so, for me, where I see most of these are young kids, they're starting to have a wider pelvis. They're starting to have like poor proprioception. And these girls that were once really confident in their body, maybe really athletic and excelled, are now feeling kind of clumsy and goofy. And so we'll see them in the clinic. And I think the biggest change that we really try to implement is really improving their motor control and just giving them some like movement like tips on how to like move your body to decrease some of this like strain on their knees, on their hips and things like that. But it's a critical time for females, like, right? Like if we talk about gender stereotypes, like what 14-year-old girl wants to be sweaty and smelly, right? Like all these changes are happening, and it's awkward. And so I think creating a space that, feels welcoming and like being a female athlete is strong and powerful is really important for this population, to empower them a little bit, that this is like kind of badass, like to be strong. Because, that's at least that's what we really try to foster in our space. But I think the motor control, we're kind of seeing that like across the literature, whether it's controlling dynamic knee valgus, that contralateral hip drop. It's a lot of that core control, I think, is really, really critical and kind of has to be addressed before we start talking about like landing, jumping, and cutting mechanics, like breaking that down a little bit. But yeah, what do you think, Amy?
Yeah, I would agree. And I think that's where, a lot of the literature, I guess, where there's the biggest sex differences in injuries does kind of come around these ligamentous. And there's so much research on like the ACL, but just because that's probably one of the most common, but it's a ligamentous injury, right? So, and it's at the knee that's where all the movement is happening. I mean, if you have decreased control, your knee is going to really kind of take the brunt of it. So, I do feel like there's a link there. And then, with running, I think there's maybe not as, there's some differences, I guess, in some trends, but like females tend to get more like hip and knee issues versus in like the male population. And this is not age specific, but it's a little more like Achilles and kind of ankle stuff. So if you're just looking at the research from a whole. But there's not like any specific injuries that were kind of related to males and females, I think, in running, like specifically, but definitely ligamentous injuries. And then definitely around these times where, the hormones have a big play, right? So adolescence, perimenopause, different spikes, and then menopause as well. Maybe you see different injuries kind of down the road. That's where I think you see some tendon issues, actually.
Yeah, for sure. And we could do like a whole separate podcast on ACL injuries in female athletes for sure. And I feel like, again, like I'm sure we'll delve into some of the concepts with that. But I think the encouraging thing for me, I was just at a conference in May, and I think it was kind of soccer focused, but almost every speaker that got up there acknowledged like the lack of research in female athletes and the need to really study them separately, because again, they are different, right? They specifically focused on injury differences with respect to hamstring and then hip and groin or athletic pubalgia, and acknowledge that like there's different trends. So there's at least an awareness out there that like, you know, the research on males is not necessarily just generalizable to females, right? There's, as we've alluded to already, there's a pretty significant difference anatomically, physiologically, right? So I feel like at least it's going in a better direction. I don't know what your sense is, but.
No, I think it's definitely, people are starting to acknowledge it, and you're hearing patients say that there's a lack of, research in women. At least I'm hearing that day to day in the clinic. So even that conversation happening, like with your day to day patient, I think is really exciting. But I still think that there's this disconnect, especially when we talk about strength conditioning programs, where we're still treating women like small men. I'll steal that from Stacy Sims, where like we shouldn't be programming the same way that we are our college male athletes. They should have different rest periods. They should have different periodization. And I think that's the exciting piece for me, is to see what changes we're going to be implementing. I think, individualizing it around their menses is something that might be down the pipeline, right? That might be really difficult to do, but I don't see why in 2025 we can't have like these really individualized programs.
So, Rachel, let's jump on that a little bit, if you could. Let's delve into that a little further. Like, tell me, what do you think? What are the essential differences we should be incorporating or integrating from a programming standpoint?
Yeah, well, I'm definitely not a strength conditioning coach. It's not my background. From like what I've been hearing from colleagues that I work with is that most of these programs are either like closer to like 4 to 6 week programs before they switch a phase. And for our females, we probably should be thinking closer to like a 3 to 4 week program, but we're actually working and training around their period, because there are separate phases where they're going to be a lot stronger that week, and then the following week they're going to be a lot weaker. And so I think it's challenging, and I totally respect that it's just a lot more work and a lot more individualized planning. But I think it's important, if we're really trying to optimize care, that this is a factor and a variable that we need to take into account.
For sure. Yeah. And I think the benefit right now is like with the rise of like sports science and some of the technology stuff, like, not that the monitoring stuff is easy, right? But I'll say it's easier, right? I mean, we have ways now with certain technology things that we can track, as far as how somebody's doing day to day, and some other metrics we can use. And I think we'll get into some of those a little later. But I was just curious to get your thoughts as far as, what some of the programming differences should be.
I think like plyometric training also should be emphasized early on. And I'm sure Amy can talk more about this too with her population, but like we try to emphasize that early on, even with our younger athletes. I think body weight training and like a 14-year-old girl is going to be really important versus like loading them up in a rack, like if she has no body awareness. And honestly, it just helps with all the things we've talked about in terms of like improving tendon health and ligamentous health. I think all those things and control and power development are really important.
So I want to pull. Go ahead, Amy. I'm sorry.
One quick thing to jump on that too. And I think so. I would say for sure I haven't even, completely figured out a way that I need to ideally train women different than men, right? And as a PT, but I know that it's out there, and I think more information is going to come out really to kind of hone in on what do we do differently. But kind of a main thing I think about is though that, so there's obviously the menstrual cycle, and like, so the having shorter programming or even just asking, okay, what is your menstrual cycle? And maybe you, during the times that they're going to be a little bit weaker, that's their kind of down week. So you're building up for 3 weeks and down, building up for 3 weeks and down. So you kind of fit that into where they're naturally going to be more tired and they get recovery. So that's going to benefit them twice. And then women in general have a little more like aerobic capacity. And I think they have a little more, they're built with more type 1 versus type 2, like ratio wise compared to men. So the plyometric piece really fits in nice, right? Where you're trying to get them to be stronger and get some of that type 2 muscle fiber activation.
Adaptation,
but also in a safe way, so you can get that training piece too. And then an end goal is to kind of, I think for a lot of especially a lot of runners that are distance runners that a lot of people come to me and they have like they just run, and then they lift weights, but they're really, really light. But trying to get them to a point that they're able to lift heavy and get some of that type 2 muscle fibers, and for tendon health, for strength building. But it takes a bit, right? It takes some time and training and getting
For sure.
good at those movement patterns. So you can't just jump right into that.
So that's actually one thing, Amy, that I wanted to touch on is what do you both perceive as far as when you're seeing some of these newer female athletes that are coming into the clinic, whether it's from a performance standpoint or whether it's from somebody that's getting rehab, what is their training history like now compared to males? Are you seeing more female athletes that have been and had some exposure to weight room stuff, or are you still seeing where, again, there's a big disparity as far as their training history and kind of familiarity with some of the technique stuff from a lifting standpoint?
So I'll go, and then Rachel, I know you'll have a different perspective because you have such a smaller, like your patients are kind of a smaller age range. Mine kind of run a span because I have high schoolers, and then I have runners that are 60 and they're still like, wanting to run marathons. And so from a strength standpoint, from a female strength standpoint, I think compared to how it was, even when I was in college, like 15 years ago, almost, like strength, and I was an endurance athlete. Our strength training would be so minimal, and it would be so like our sprinters would strength train. So at least there were female athletes, like those power athletes were strength training appropriately. We were not. In reality, it both needs to happen. High school athletes that come to me, I think the females have a much better sense than they used to. They know what a deadlift is. They know what they've used a squat rack. I will tell you, in high school, I never used a squat rack because I was distance. Like you would never do that.
Sure.
But so they know these movement patterns, but I would say like when you dig a little deeper, they really don't have a good handle on it. And then compared to males, they'll have a little bit better handle, but also because they tend to be kind of interested in it, and they'll go on the gym on their side and do stuff with each other. And I think they're looking up on social media a little bit more. And so they have a better handle on it. But female, there's definitely a disparity that I see. And then when I see patients that are, let's say, older than 40, no idea strength training, like haven't even ever done it before ever. So that where I'm like, oh my gosh, like I'm gonna like blow your world because I'm gonna tell you like 2 things and you are gonna run so much faster and feel so much better. And that's it. Like it's a low-hanging fruit for that population. So it's like a big there's some generational gaps there for sure.
Yeah. But a big window of opportunity for you also. I mean, again, both like from a performance standpoint, right? And clinically. Yeah. So awesome. Yeah. Rachel, do you have any thoughts on that?
Yeah, I will say like for the population I treat, I really struggle with this because I do think there's so much more information out there. I would say most of my 14-year-old girls are coming in with like a TikTok program, which sometimes is great and sometimes is not so great.
Right.
But my biggest barrier right now is like trying to carve out some recovery. Most of my patients play for club soccer and they're training or competing 6 to 7 days a week.
I understand all too well.
Oh my gosh. Yeah. And it's really tricky because they're specializing so young, and these are really talented athletes with big dreams of competing at a higher level. And the last thing you want to do is like crush those dreams. But when you're 10 years old and you're coming in for your 4th or 5th injury because you're sleeping 5 hours a night, you're not eating, and you're playing 7 days a week, like it's hard to like as a clinician be like, what is going to be the most impactful exercise I can give you that is not going to burn you out, because you're already moving so much throughout the day. Burning the candle at both ends. So I find it really challenging, and I think a lot of what I'm doing is talking about the importance of sleep, the importance of recovery, talking to the parents about like commitment and what is our long-term plan here. But yes, I think overall I've seen a trend of like girls are coming in with a better understanding of like, I need to exercise and lift on top of what I'm doing, but there's like only so many hours in the day.
Right. And there has to be like some sacrifice as far as overall volume, goes, and like you said, building in some of that recovery time. But that is an awesome segue into my next topic, if you don't mind, this whole idea of overtraining. If you could both tell us a little bit about relative energy deficiency syndrome. And I don't want to like narrow it down to female triad because obviously we see relative energy deficiency in males and females. But I feel like it's probably more a little, you can maybe speak to this better than I can, but I feel like it may be more prevalent in especially a female running population. So I'm going to give the floor to both of you. If you could tell us a little bit about, maybe if you could just explain what it is first and tell us about like kind of what you see in some of your athletes that are presenting with it.
Yeah. So, so I guess Red S is kind of where we used to call it the female athlete triad, right? And there still is the female athlete triad. And I think that piece is just more specific to females, but Red S can be male and female, and it's stands for Relative Energy Deficiency Syndrome. And I think about this as like, this is the person coming to me maybe with like what Rachel, you just described is like, they're doing, like, you're kind of talking to them, how often are you exercising? What are you doing? And, what are you doing for exercise? And they are just 0 rest days, like high intensity, like more, like really high intensity, more than 3 times a week. And you're starting like, like, that's also where honestly I'm like, I gotta look for bone stress. Like this needs to be part of the picture no matter what, because you start like really breaking down the body. But it's someone where it doesn't just affect your, you coming in with pain, but then you're also, it affects your performance. Like you're not able to, like you're training as hard as you can, but you're not getting better. You can't run faster. You can't jump as high as you used to. And you're like, people are coming in like, what the heck is wrong with me? I'm doing all the things. But that's where you really, I'll dig into kind of what is your eating habits? What is your sleeping habits? What is your workout? Like, when do you work out and when do you rest? Like, what are your rest habits? And so how do you, how do you or your team kind of, or your coach put in the recovery pieces? And so I'm trying to get a big overall sense of that and then kind of digging a little bit deeper. But I think the biggest thing is it's such a multi-pronged kind of syndrome where it is, you are not able, your body cannot give any more, there's no more output happening because there's not enough input and there's no regeneration of any of these energy systems. And so it starts affecting everything, concentration, mood, even your heart rate, which as a fit person, you think it's going to go, your resting heart rate should go down. Yeah. Like people might start noticing like, and I think at least all my patients have Garmins. They're like, my Garmin told me this. So like, it's actually can be a good kind of a good check. I don't think we need to be like always looking at our Garmin and hopefully that doesn't make for how you plan your day. But basically, if you're seeing like your resting heart rate going up or your recovery just not being adequate, those are some big red flags. And I will have conversations kind of about all of those things. And then, obviously, if it's coming to, if there's like a disordered eating piece of it, that's like a whole, that is where they need some separate care that is, needs to be very well done. And very sensitive, there's a lot of sensitivity around it so that they're not feeling like they're just a failure. They're trying to maybe use eating as a way to control the rest of it, but it's actually not enough. And then that is like a huge piece with definitely, I would say high school and collegiate runners, probably more so than, and maybe that's also because the people that have those issues don't get to professional level. If you're thinking about performance standpoint, because they just can't, too many injuries.
So I want to follow up on that, Amy, if we could, just because I'm guessing, I don't have any demographic studies, but I'm thinking most of the audience that would listen to this is largely clinical. So tell us, like, the soft skills are definitely important, right? So can you tell us, like, how do you kind of enter in or broach that conversation with them, if you can?
So I will enter in a way of, I will start just asking questions of, okay, so you're training. So basically I start with like how much they're exercising. So I'm kind of trying to paint a picture for them without like accusing them. I'm like, let me paint this picture over here and tell you. And then they're kind of able to like step outside of themselves and be like, oh, that's a lot. So look, so this is where you're exercising. Okay, but where do you, where are your recoveries? And they're kind of like, I don't know. Okay, well, let's think about that. If someone else was doing this, would this seem like a lot? And then I go into sleep because like I think that's easy. Like nobody's like I'm a bad sleeper, like, oh my God, I'm a bad person. I think sometimes when it comes to eating, people feel like, oh, I didn't eat healthy today, I'm a bad person. I think that's cultural. But so then I'll go to the sleep next. Okay, well, how much are you sleeping? And sometimes it's good, sometimes it's bad, because that's going to regenerate you, right? And then I'll kind of go into the eating. Do you have any special diet? Like, do you avoid certain foods? And is it because you're allergic to it? Is it, you grew up in your whole family as vegetarian? Or so I'll talk about the importance of protein, carbohydrate, and fat, and I just talk about that as a whole. And then I will not necessarily day one try to diagnose them or ask them about, I will ask if I feel very suspicious, or if they, like, I would be more suspicious of a bone stress injury if someone's diet is not normal, or they don't get enough meat, or after we've had that conversation. But then I'll talk to them about, do you think you need some help with managing your eating to make sure that you're getting enough? Like, it sounds like you're not getting enough. Like, I'll kind of play it that first, and then I'll, visit 2 or so, I'll kind of get a little bit more into that. Because I don't want to, last thing I want to do is turn someone away. Because that can be that can happen very quickly. And it also can really break the trust between, as a PT, I can't diagnose you with an eating disorder, right? But I can tell you, that seems like you're not getting enough, but here are my recommendations. Is that something you can try, and then also, it's not my, expertise. So are you interested in seeing, a nutritionist or somebody to help get you on the right page? Because either that, or it's not going to help you recover. That food is going to give you the energy to do well. And then your body is going to recover and respond well. So trying to use food as energy. It's energy, right? Versus calories.
Fuel, yeah.
I always say like energy instead of calories too. And I think I've changed that over time just because people respond to that really well. It's a subtle thing. It's funny, even my girls. So I have a 5-year-old and a 7-year-old, and they both they have no concept of any of this yet. But they're like, what are those numbers on the back of the chips? I'm like, oh, those are calories.
Yeah.
And they're like, 150, that's a lot. And I'm like, no, that's energy. I was like, so all the food you eat has energy. And some energy is better than others. And these chips are, they taste good. They're not good energy, but they're okay. Like, they're still energy. So it's fine. But as long as you're eating, and this is where I talk to them about this, like, as long as you're eating the healthy food and you're getting the energy in, that's good. But because I guess I'm just aware of it. Even as girls, I don't want them to be like, oh, how many calories are in there? Like,
right.
But I don't want them to think of that as bad. It's just, those are energy. Like, and be mindful about like what's going to give you the most energy. Try to eat those foods, get the most bang for your buck.
I feel like that's a hugely important point, that like, again, that the using some of those soft skills and kind of separating, because I do feel like, people, calories by themselves are like this just like energy metric, right? But I feel like culturally it gets lumped in with like weight control and that kind of thing, right? And I do feel like that's an important point, where if you pose it to an athlete as like, this is energy, it's a distinction, but I feel like it's an important distinction and helps kind of control that mindset, and like you said, develop that like therapeutic alliance or rapport, to where there's a little bit of a trust that goes forward, and you don't just hammer them right away. So I feel like that is important. Tell us like how, just for the general practitioner who may treat the occasional runner, like what should they be on the lookout for clinically? Like, what are some of the warning signs before, that would make you suspicious?
Suspicious of like red S.
Yes, yeah, sorry.
Oh, okay. Yeah. So high mileage, less than 1 rest day. So like no rest days for sure. But even, sometimes, minimal rest days. Generally, if someone is talking about their performance going down, I start like, why would that happen? If you're training appropriately, your performance shouldn't go down. And then just sometimes just feeling unwell. Like, they'll describe not feeling good and always feeling tired. and maybe even they're like, I don't know if my patients really are like, oh, I'm not doing well in school, but generally we talk about fatigue a lot.
Yeah.
So like a large amount of fatigue is probably the biggest thing, from like a red S standpoint for sure. And then history of, this is a big, I mean, if they have a history of bone stress injuries, that's going to be like a red flag to me. And then also just certain sports. So endurance athletes, just because they're asked to do. So, I mean, their mileage or their output is so much, so many minutes. So endurance athletes in general, runners, swimmers, and also gymnasts, honestly, are like a big one. And I think that's because that lumps into like the, previously we would call it like the aesthetic sports.
For sure.
But
So
males, you want to make sure that you're not biasing, right? So like,
right.
so these are the obvious ones, but then males, same thing. If they're coming in and they're talking about their performance decreasing, they're having no rest days, they're like totally overdoing, or they're in, like Rachel, you said, they're in 3 different sports and they're doing all 3 all the time. And they're starting to get some pain somewhere. I'm going to be concerned about that as well.
So is there like a formal screening tool that either of you use, or like a patient-related outcome score, something along those lines that you implement, to kind of screen for it?
I don't use a screening tool right now. I mean, I think there's like the LEAF screening tool that's
Right.
out there. I haven't used that per se.
Okay.
I probably should, but it's a matter of
Okay.
kind of like how, what does it kind of give you in the end? I think it
Sure.
would be very specific, and it could also really kind of get the patient. I think if the patient is not on board, I would probably give them a questionnaire, to kind of back myself up.
Okay.
Rachel, are you using like any questionnaires for Red S?
We use the Leaf Q. I think, also just to drive home Amy's point, I think that there's a very specific type of person that this Red S usually kind of is coupled with. It's usually a very motivated athlete, very type A, a little anxious. I think they usually come in very anxious about when they can return to sport. Sometimes they're a little bit emotional, especially if they are in the thick of Red S, where that's one of the like warning signs, right? We've got some behavioral changes, some mood changes.
Yeah.
I think to your point about like suspicion of disordered eating, I almost always tag a parent in when I have that part of the conversation, because an adolescent teenage girl is going to say she eats fine. She's never going to talk about, but, I eat more than my friends do. I'm good. And then just like adding that into the conversation, I almost invariably will get an email from my mom later and be like, yeah, she never eats. She skips dinner all the time. She's very conscientious. And it just helps like advocate for the athlete when the parents are involved in that conversation, because these kids are generally unwilling to change. Like even with the most severe of injury, they are very motivated, do not want to have any time off, do not want to wear boots, do not want to be in crutches. They're very like self-conscious, about how they look and how they're going to present to their peers. So a little bit of a different population than Amy's seeing currently, but I can usually spot this person as they like within the first 2 questions on my subjective history. And I think when we talk about bone stress injuries, like the location of pain, the quality of pain at night, those are all things that we're starting to ask to try to qualify that a bit. I know we want to talk about BSI a little bit too. So.
Well, I definitely want to get into the bony stress injury, and also finding out your approach, because I feel like rehabbing the bony stress injuries is an art in itself, right? And knowing like how to progress and volume wise, that kind of thing. So I do want to get both of your thoughts about that. So before I get into the rehab side though, tell us, from a bony stress injury, what are you seeing? How do you diagnose it? How do you handle it or manage it? Like, who do you refer to? Those kind of things, if you could launch into that.
Yeah, Amy and I were talking about this earlier, and I think like the majority of being a good clinician if you're working with this population is just taking really good subjective history. Like the actual interventions you're going to do is like what we do day in, day out. It's just recognizing that like, oh, I'm dealing with a BSI. Because I think it can be easily missed. It can be like misdiagnosis plantar fasciitis or something else. So I think making sure you're taking a thorough history. I think volume of exercise. I think asking about performance, like Amy talked about. My two big ones that it is a BSI until proven otherwise is pain at night and pain at hopping, because it's mostly lower extremity. So if they have sharp focal pain at their location of injury with hopping and they're having pain at rest, pain at night, it's a BSI until we've ruled it out with an MRI. We're very lucky in our area that we have a group of providers that we work with very closely. I think having like a multi-D team on this is like imperative to long-term success, like making sure that we're getting appropriate labs, getting appropriate imaging, working with nutritionists if needed. But those I would say clinically are my big red flags. Amy, am I missing any that you look at?
No, I think those are good from like a clinical red flag standpoint when you're thinking of symptoms. Right. Subjective history, obviously that's painting the picture and you're like, my suspicion's going up. And then it's like that, either with some point tenderness, night pain for sure. Or like I'll have runners that I've had over the years, I've had quite a few like femoral neck, like stress fractures for runners and that's where you're like, you're doing all the tests. And you're like, none of these are positive. The amount of pain that you have does not match up with because they come in with a hip flexor tendonitis or something like, or they come in with this tendon diagnosis and you're like, this does not make sense. It's always the week before the Boston Marathon, so that's helpful.
Yeah.
I'm like, so you should get this image or just run. I don't know, like it's crazy. Right. But yeah.
If
and
you
so
collapse in the middle of the course, there'll be plenty of people around, right?
Oh my gosh, yeah, it's crazy. And you're just like, oh, I knew it. Like I've had people that have listened and then other people that haven't, and you're like, ugh, like now you are just like, you just ran through that and now you're in for like a long rehab.
Yeah.
But yeah, getting a good team together and an MRI for sure on those people that you have a high suspicion, because X-rays are gonna generally they're not gonna be sensitive enough.
Right? Yeah.
Right. A lag, or like if there's something brewing, it's not gonna be sensitive enough.
Yeah. So tell me, as somebody that doesn't see a ton of running patients, tell us what body site do you see them most clinically? Are most of the ones you're seeing tibial? Are you seeing a lot of metatarsal? Are you seeing, you mentioned femoral neck or pelvic? Like, what do you encounter most often?
I actually see kind of a mixed bag. Yeah, I mean, but like if I were to say kind of like 5 common sites that I've seen like more consistently would be, so like femoral neck, tibial for sure. I've seen a good amount of sacral stress fractures.
Wow. Okay.
Yeah, I know. And then metatarsals, or I've seen a good amount of cuboid stress fractures, and I don't, maybe that's overcorrect. I think some of it tends to be kind of foot mechanics and overcorrection with some of the footwear. So those are kind of the main ones that I see.
Okay. Rich, same question to you. I don't know what you're seeing since you have a little different population.
Yeah, we've seen a bunch of bilateral, like distal tibial stress injuries, and like pretty bad grades, like grade 3s bilaterally, which is really, it's really hard to convince a high school girl that she needs to be like in a wheelchair ideally for a couple of weeks.
That goes over well. Yeah.
Oh my gosh, it's terrible. But yeah, we definitely see the more low risk I would see in my population. We did have a couple of femoral neck in our runners, like cross country runners last year, but they came in really late. I think that's what happens is this population, like inherently running is uncomfortable and training is uncomfortable, so they push through pain. That's what makes them really talented athletes, but it's also a blessing and a curse. So we have had a couple of like 5th metatarsal coming in lately and like 3rd metatarsal, so to Amy's point, like foot mechanics and things like that. But I would say distal tib is probably the number one, and tenderness, palpation, focal pain with hopping, pain at night, those are our big red flags.
Yeah. All right. And also, as we've alluded to already, again, as the parent of two teens, I know like self-awareness sometimes is like, like recognizing, hey, this is not normal, or, right. Or just, whatever. So, yeah. So tell us, like, when you see them, obviously this is multifactorial, right? It'll depend on the grade of the injury, the site of the injury, and that kind of thing. But from a progression standpoint, how long are you typically shutting them down for in these, especially since the majority of these are endurance athletes? What do you do to substitute to make up for that lack of like endorphin release, or as an alternative form of aerobic exercise for them? Give me a little bit of insight into how you're managing them for both of you.
Yeah, I mean, depending on the grade and location, like high risk, low risk, I think is really important when talking about timelines. But under the pretense this is a low risk, grade 2, we're probably talking about shutting down for like 4 to 8 weeks, depending on that scale, which is really tricky because that's probably going to finish somebody's season out. So it's not a great conversation to have.
Nope.
I think what we really try to focus on, the first thing I say if we confirmed a BSI, is that we talk about risk factors of this happening again, and that we don't want this happening, because it's a pretty devastating diagnosis for a high school athlete. So, the number one risk factor for a BSI is a history of a BSI.
Right. Yeah.
We don't want to see this again. So we'll use a lot of BFR training in our clinic during the acute phase, because I feel like our athletes feel like they're getting that like rate of perceived exertion that they're craving. Otherwise, if we're just doing table-based stuff, it's boring as heck. They don't feel like they're getting anything. At least with the BFR, there is some evidence too that helps with some like bone healing. So I think it's just like, it's so hard that they feel like they're training and doing something and working towards their goal. But yeah, that we're shutting them down usually for like a minimum of, I would say, 4 to 6, right, Amy?
Yeah, that's what I was saying. And with this though, I try to like jump right on trying to talk to like their referring provider, or at least the provider. Maybe I referred them, but like we have kind of a conversation about, because also like, how long do you think it's been going on? Like, because you're like, well, do we go by like onset of symptoms, or when they had their MRI? So we kind of like talk back and forth between that, and then obviously clinically you're looking at, so there's like the timeline, but then there's that criteria where they need to be if I'll jump to like if they're returning to running, but that's where running is usually like probably one of the first things for when you're returning to sport. You're like, if you can't run, you probably can't do your sport. But they need to be able to like walk pain-free. Obviously, they need to be able to single leg hop pain-free. And then a certain amount of healing needs to have gone on, right? 3 to 8 weeks minimum. Sometimes it's like close. It depends, right? If it's a higher risk spot, like that's the 12-week period. But I'm talking with the doctors kind of like, when do we think? And then like when these clinical boxes are checked, then we kind of progress them. And then the big thing is, okay, well then what does that look like? So, making sure, like Rachel, you just said, like we need to talk to them about their risk factors, like make sure those pieces are in place during this time. Cross training has happened during this time too, so they're keeping up their aerobic endurance, or at least just some fitness. So whether it's combination of BFR and like being on the bike or pool running, or honestly, I don't really have people use the elliptical that much, nor do people like it. It's usually like bike or kind of pool for unweighted. And then there's also some different tools out there for if you want to do some like unweighted treadmill running, if people have access to those like things.
Alter G or
Yeah, and actually there's a company, and I do not work for them, but there's a company out there called Lever Movement, and it's a much cheaper version of an unweighting, and it's not, I mean, you can get up to like 45 pounds, so kind of whatever percentage of that body weight. So that's a great way to get runners they hook it up to their treadmill, and you can actually rent them for $100 a month, so people don't need to buy it. So it's actually a great resource versus Ultra G used to be the only one out there, and that's like a $10,000 machine. Who has that?
Little cost prohibitive for a lot of people.
Yes. But yeah, and then that return to running, I mean, we just use the principles kind of that have been there for a long time, but 10% increase or less kind of each week. And then just monitoring people as they go along. But the entry point, it depends on the patient, I think, of like how much running do you start with, right? Not everyone starts at the same point.
I think like making sure when you're doing your assessment and okay, we've diagnosed them with the BSI is like figuring out why. And sometimes it's just volume. That's a very easy thing to retrain. But if there's something mechanical that we need to address, some control issue we need to address, I think using that period of like rest and like that progression, like that sweet like 6 to 12 week period is when you're like hunkering down and really like, let's look at control, let's look at movement, look at strength, let's get you some objective data so we know like, all right, how's our hip strength? You know, we've been using, we're asking all of our female athletes to hit 30% of their body weight for their absolute value of their like glute med strength. So we're seeing some evidence if they can hit that, which is it's a high number to reach, that their risk for lower extremity injuries like goes way down. So we're working towards getting that, and especially with this type like A athlete, that metrics are going to be really critical. Like using your limb symmetry index testing and being like, well, you're only 80%, or you know, within the normative value, this is where you're at. We want to see you here by this timeline. We're going to start the running. And then anecdotally for me, Amy, I don't know if you use this, but before I even talk about running, I make them do like a 30-minute fast walk and just see if that aggravates their symptoms before we really even start introducing like a return to run program. Because if they can't like walk fast for 30 minutes, to me, the bone is just like not ready yet. And that's just been like another little checkbox for me to like, all right, we have to do that before we start the next phase.
Yeah, and I actually have them do, honestly, I have them do a walking program for 2 weeks before. So like I would know, because like I get a little nervous that if someone isn't, like if I have them just jump in. Not that I'm saying that you do this, but that 30-minute fast walk is a good pulse. But before that, I'm going to assume like, let's assume like they're not going to pass it, right? I mean, that's not a great assumption, but you want to like work them up to that first so that you have a sense of like, is that going to go well or not? So I'll progress them walking first, like go out for, you know, a 20-minute walk to 3 times a week and then kind of build that onto their schedule.
Got it. Okay, awesome. I do have based on the points that you both raised, I do have a couple follow-up questions. Tell me, in the return to walking, return to running, rehab progression, does bony tenderness matter? If they're still tender, is that shut them down, or do you feel like, that's pretty normal consequence and still part of the healing process? Yeah.
We use soreness rules with us, but I think it depends on location. Truthfully, if it's a low risk, I'm gonna entertain a little bit of soreness. But I think if you're not palpating within each visit, you're definitely missing some information that's critical for progression. And if it's like where their focal tenderness was on day one and it's really bitey, like we're backing off. Like there's just no need.
Gotcha. And then tell me,
I would agree with that 100%.
Awesome. Okay. When you implement the BFR, how are you doing the traditional like 70% limb occlusion pressure, you know, 1 set of 30 followed by 3 sets of 15? Are you doing it as like a pre-ischemic conditioning kind of thing? Like, how are you implementing that? Just again, for clinicians that may not be treating this on a more regular basis.
Yeah, we've been doing it as part of our conditioning program. Like we'll have them do some like intervals on the bike when they're ready for that.
Okay.
Which is like just a cruel thing to do.
I was just going to say, I'm sure that's super comfortable for them and they love it.
It's a terrible thing to do. And we always joke about it because they like hate us, but love us after because they feel like they're doing something. But yeah, we do a lot of like 2 sets of 20 for all of our like, you know, open chain exercises when they're starting to do some closed chain. And then we do a lot of fatigue protocol. So that like 4 sets, like first of 30, 2 of 15, and the 4th to fatigue or failure with that minute of rest in between. And I usually have them finish with that because they're fried after.
After that, they want, they just want to die on the table, right? So, right.
But the ischemic preconditioning, I truthfully have heard about it. I haven't implemented it into my daily practice because of the time constraints in the clinic, but I think there's a lot of evidence to support it for sure. Amy's the BFR queen, so she probably can speak to that more than I can.
I was going to say, have at it. Yeah, I'm curious to get everybody's insight because I know.
Well, the pre-ischemic conditioning piece, honestly, I haven't implemented that as much into my actual clinical practice because also you need to be doing that daily. So I would say when I use BFR in the clinic, right, if people are coming, I actually have people come, I never have people come more than twice a week. I mean, a lot of my clients are honestly coming once a week and they're doing stuff at home. So I'll do, I think it's still worth BFR if they're coming once a week, but that would usually be, if I'm going to do that, I have people that buy their own units. So like, then I would
BFR,
say, yeah, because I don't want to do too much time on that where like, I almost feel like with BFR, so it's like a great novel intervention, and also you can get such benefits, but it does need to be like at least twice a week, so to get actual benefits. But if I'm going to teach someone how to do it and they're like kind of buying into this and they want to do it on their own, then I'll have someone get it, or I'm sticking with, honestly, Rachel, what you're saying, like you can give them intervals on the bike to maybe get their cardio up. But to be honest, that's where like I would probably be telling them to kind of do that on their own. Like they're not necessarily coming in to see. That's not really how I run my practice, because I am a lot more, they're coming in for like hands-on and looking at different movement patterns, progression of their program, and things like that. But the way I would use it is certainly from a strength standpoint, or from conditioning, where you're just doing continuous compression at like 60 to 80% limb occlusion pressure.
Yeah. Okay.
Yeah.
I know we only have a couple minutes left here. I know, because none of you are being paid to be podcasting guests, right? So I did have one kind of my own personal curiosity question. Again, as somebody that doesn't feel a lot of runners, but I know that, again, the rise of like wearables and all the technology stuff. Is there any tech that you are both implementing in your practice, or that you're strongly suggesting that people purchase or use on their own, that helps you clinically, or you feel like has been a big game changer for them? Or maybe not. I'm just curious. Yeah.
Well, so when it comes to gait analysis, I have this, I use this technology called Run Easy, and it's awesome because I've when I worked at Mass General, we had this like crazy lab that had all these cameras and force plates and all this stuff, where someone would come in and you do this gait analysis and you have all these numbers, and it was awesome. But also, like, that's not feasible. And it definitely, as someone opening up my own practice, I'm like, how am I going to do, this gait analysis where you get some numbers?
Yeah.
But also, honestly, so much of the gait analysis comes from like what you're seeing and then what you're evaluating and it comes from the clinician, right? But so I use Run Easy, which is it's basically a little accelerometer, and it clips onto like a belt, and they put it at like L5 S1, and it gives a little more information than like what a Garmin gives. So it gives you some numbers for impact loading, symmetry, and dynamic stability. And it's really great as an interface for patients, because trying to explain gait to someone, I mean, it's like you totally get into the nitty gritty, because people want to hear about the nitty gritty, but then you explain it and they're lost, right? And you're like, okay. So really, I think it gives some good pictures, and it kind of spits out this PDF with a good visual of like, these are the big points. And then I will loop that into like, I have a video analysis where I'm like, okay, and see, this is where like your impact loading is, not as good on your left side because you have some glute med weakness here. And that's likely because of X, Y, and Z. And so I'll use those things together. But I don't have them purchase that. I mean, a lot of my patients have some sort of smartwatch, and those are awesome. But I mean, there's a good and a bad of everything, but it's awesome when you're trying to kind of look back and see some trends, and you're like, oh, okay, like, or this time, like when you started having pain, like let's say your cadence changed, or like what, or you got, something changed here, or you look at, that's where you got mileage, you got like all these things. So it's a great way to look at patterns with some of these smartwatches. Primarily, like, I mean, I think people mostly have like Apple Watches, or like some level of Garmin, like a lot of Garmin's and Coros, but all these watches kind of give the same information. That's kind of like the most tech that we use, I would say, true tech, like.
Okay.
Yeah, my high school kids, we don't have any wearable technology, but I would say the Apple Watch is probably the closest thing. And the metric that I typically encourage them to look at is cadence. It's just the easiest one to try to control for in our space.
All right. Awesome. Well, I know we have to wrap up, but you two were gracious enough to come on. So I want to kind of give anybody that's listening a chance. If they have any follow-up questions, or if they want to pick your brain with more insightful questions than I had, where could they find you or reach you? So Rachel, I'll let you start if you could.
Yeah, email is probably the best way to shoot me a line. It's Rachel@kinesipt.com, KINISIPT.com. You can also check out the website. Like, we're always doing some cool things for our female athletes. I'm always looking to connect with people with similar goals. So yeah.
Awesome. And Amy?
Yeah, and same. Probably email is the best way to just directly connect. It's amy@tempodpt.com. So tempo like a tempo run, and DPT like Doctor of Physical Therapy.com.
All right. Awesome. Well, thank you both again for coming on. This was like, again, like for me as somebody that doesn't treat a lot of running injuries, and sees a fair amount of female athletes, but always good to get like from people that do it on a more regular basis, always good to get your insight and perspective. So thank you again for coming on.
Thanks for having us, Dan.
All
Yeah,
right.
thank you for
Great.
having us. This was great.
All right, cool. Both of you have a great day. Thanks.
You too.
Bye, Dan.
See ya.